Hi, this is Neil Dilworth, and today we're going to be talking about apophyseal injuries in sport. I have nothing to disclose. I'd like to thank the following colleagues, Dr. Steinbeck, Dr. Bleakney, and Dr. Smith, for their donation of cases today. And today, the main objectives are to be able to describe the various locations that apophyseal injury can occur in the pediatric population, for you to understand the terminology relating to apophysitis, and finally understand the potential complications and differentials to apophysitis. And that's essentially going to keep in with our outline to today's talk. It's going to essentially start off with the background information, and we're going to go right into cases then. So when we take a look at a AP X-ray of a pediatric hip, this is a child that's around 10 years old, really allows us to see the different anatomical terms that are used and why there's a difference. You can see at the end of a bone, you have what's called an epiphysis at the femoral head, and that refers to the bone on the other side of the growth plate, and typically these articulate with another bone in the realm of a joint. The line between the epiphysis and the rest of the bone is called the physis, and that's essentially the growth plate. The transition part from the shaft of the bone, which is the diaphysis, is called the metaphysis, and in here that would refer to the femoral neck. And then there's the apophysis, and the apophysis is a secondary ossification center. It looks very much like an epiphysis. What's different is that it does not articulate with a joint, and in most cases it's for the attachment, either origin or insertion of a tendon, and in some situations it's for a ligamentous attachment. The other one that we don't see here is in reference to an os. Sometimes you can actually have an acetabular os. Those are also a ossification center that and anywhere between 5 and 10% of the population will have some form of os somewhere in their body. And it's just essentially a secondary ossification center that doesn't fuse with the original bone. Most commonly found in and around the foot. One of the commoner ones would be a os trigonum at the back of the ankle, the back of the talus. So when we go through the literature, there's a number of terms that come up, and you can see these in association with either articles that talk about apophysitis or apophyseal injuries. First one is an osteochondroma. Osteochondroma is generally speaking a benign exotosis or bone protrusion. It's either can be sesamoid or pedunculated. You can see it here in the top left here, coming off the lateral aspect of the femur here. Osteochondrosis is essentially kind of referring to generally the any kind of dysfunction of the bone and cartilage that can encompass epiphyseal injuries, physeal injuries, as well as apophyseal injuries such as apophysitis. So it's kind of an overcompassing term. Myositis ossificans, this is essentially a bony growth, usually secondary to trauma that occurs within muscle, and you can see that in this case here within the hamstrings. There would have been a hamstring tear at some point, and where the injury occurred, this kind of bony calcification growth occurred. Heterotropic ossification, this is a common complication of apophyseal avulsion fractures. You can see that in the bottom right with respect to a lesser trochanter. And they can look quite irregular, and sometimes concerning. The other times we'll see that is in adult population. It's very commonly seen post-operatively, especially in around hip replacements. And then there is a tug lesion, which is a partial avulsion, usually of an apophyseal site that's the bottom in the middle or bottom center, And this is the medial aspect, posterior medial aspect of the femoral supracondyle. That is the attachment site for the adductor magnus. And then finally, there's something called cortical desmoid. Sounds quite concerning. In fact, these are benign fibroosseous lesions. You can see it almost looks like a cystic lesion, followed by some cortical irregularity. This one here in particular is at the medial gastroc origin attachment, and the other common area for cortical desmoid is once again similar to the demonstration of the tug lesion here, is at the insertion of the distal adductor magnus. Now, when we speak specifically about the apophysis, some of the concerning things in the earlier literature that was kind of interchangeably used with epiphysis, and it's unlike an epiphysis, it doesn't contribute to a joint like we're talking about. It's normally for the ligament or tendon to attach. There are a number of apophyses throughout the body. Essentially, wherever you have an apophysis, there's a potential for having an apophyseal injury. More often than not, an apophysitis, and occasionally with acute trauma, an apophyseal avulsion fracture. I've bolded the two commonest, most people are aware of Osgood-Schlatter, the tibial tuberosity, and the severs, which is a calcaneal apophysitis. I've also attached the two cortical desmoid. Although you can get a fibroosseous lesion, it's believed actually be cause secondary to essentially chronic or acute traction of either the adductor magnus or gastrocnemius at their insertion points. When we talk about the apophysis, there's essentially an injury spectrum, which is important to keep in mind. So there is a traction force applied. Let's, for example, use the adductor magnus, and there's a pulling force pulled on its insertion. Now, if that's occurring repetitively over time, that would be chronic, and the most common injury that would occur from that would be an apophysitis, and therefore it will be tender to touch, and it may essentially come and go, get worse with activity and better with rest. As the individual continues to play on that injured area, then they can actually start to develop a traction apophysitis, which is a separation of the apophysis from its diaphyseal origin. And the other one is a cortical desmoid, which we talked about, which is a fibroosseous deficit that occurs just below the attachment of the muscle. And there's actually been some cases of osteochondroma occurring at the apophyseal site. Now, most of those are actually non-tender when they occur, but there's potential for causing pain, but also further injury just because they tend to be quite prominent. Now, on the acute side of things, we get an acute tractional force, then we can either have an avulsion fracture or a tug lesion. Keep in mind, if it's a lesser force, it may be the initiation of the apophysitis, but generally speaking, when we're talking about acute here, we're talking about a sudden, one singular sudden movement or force that occurred during sport and which led to the player to stop. The avulsion is the separation, acute and sudden separation of the apophysis from the remainder of the bone. And one of the secondary complications from that is heterotropic ossification. Non-union can also occur as a result. And the second one is a partial separation, which would be a tug lesion. So the histology behind apophysitis. So people thought these were growth plate injuries. They're not. Growth plate injuries are not related to any kind of growth plate or growth interruption. They're actually, it's better to think of them almost as an enthesitis or an enthesial injury in the pediatric population. So we see these kind of chronic partial microavulsions of what is a kind of a mix between fibrous, bony, and cartilage material. It's kind of the transition point between the tendon and the bone, or the enthesis, and that's where the inflammation and the pain is coming from. On MRI and on histology, what we're seeing is increased osteoblastic activity on the histology. On the MRI, some bony edema. And then once again on the histology, we're seeing some benign spindle cells and small vessels coming into the intratrabecular space, along with some inflammatory cell infiltration. So the population we're talking about here is essentially a healthy pediatric population that's partaking in sports. And generally speaking, these are overuse injuries. It's quite uncommon to have a tendinitis in the pediatric population playing sports. They can't get muscle injuries and musculotendinous injuries, but depending on their age and the stage of development, if the area that injured is associated with the likelihood of a growth plate being open at the apophysis, it's most likely that they're dealing with an apophyseal injury. And so therefore we go for either an acute or a chronic mechanism. So the chronic is more of an insidious, it's been bothering me for several months, I don't recall a specific injury, whereas the acute is, a week ago I went to kick a ball and felt a pop at the front of my hip. The examination will typically reveal well localized bony tenderness in the absence of any kind of joint findings, but it's very important, keep in mind that these are overuse injuries, that we are examining the other joints for these children, because it's not unusual to pick up an effusion in an other joint not related to the injury they're seeing you for. And there has been some demonstration in the literature of association with other osteochondral injuries such as osteochondritis dissecans and osteochondral defects. In terms of imaging, we use clinical assessment to guide that. In chronic, it's often not necessary. However, it's based on the location of the injury, the type of sport the individual is playing at, and the level that they're playing at. In an acute injury where there's been a mechanism of injury, I typically would recommend getting an x-ray to take a closer look, rule out avulsion or other fracture injury. Ultrasound has also been demonstrated to be useful. In literature, they do mention bone scans. We don't typically order bone scans in the pediatric population here, but that is commonly described in the literature as a test used to take a look at apophysitis. MRI would probably be the next best bet. CT obviously would give a decent image, but we will try to avoid any radiation in these kids. In terms of treatment, it is very important for the most part that we protect the area. Now, for smaller apophysitis injuries, you can essentially manage them with essentially playing as they can tolerate and asking them to modify or load manage their activity when the area becomes more painful. There's a couple areas you want to be a little bit more careful with. The first one is in around the pelvis, especially with the large proximal muscles, such as like your adductors, hamstrings, and quads. Those typically are taking longer, 2 to 3 months, and you really want to have a period of rest and protection from activity so the apophysis can calm down completely, and then they can gradually essentially load that enthesis in terms of a rehab going forward. The other areas that you want to be concerned about, one is specifically the tibial tuberosity because of prolonged issues and fragmentation that can occur that can cause chronic anterior knee pain as an adult for the patient. So it's very important with Osgood ladders that the patient isn't pushing through pain and continuing with activity even though they may be limping. It's very important that if they're limping, that's definitely a time not to be participating in that. They should be resting. And also to consider in season, periods of a week to shut down if it's preceded by increased level of activity and increasing level of pain in the area. And the final one is the medial epicondyle apophysitis, and specifically in pitching or overhead athletes. Very, very, very high preponderance for recurrence, and there's good study, which we'll see, that took a look at throwing athletes over a period of 3 years, which we'll take a look at. And so that's another area that you really want to shut them down from the throwing activity altogether for a good significant period of time. You're looking at about 6, sometimes even up to 8 weeks, and aiming for it to be non-tender to palpation for a period of about 4 weeks before reintroducing the throwing. So in terms of the upper apophyseal locations, these are I will say calmer locations upper. It's definitely less common than having an apophysitis in the lower limb. So you can have an acromial apophysitis, the Lessertuberosity, where your subscapularis inserts, the deltoid tubercle, the medial epicondyle, where your pronators and flexors originate, as well as your UCL, your ulnar collateral ligament, and then as well as the triceps insertion into the olecranon. So the acromial apophysitis essentially is described in a number of sports. Once again, overhead basketball and baseball, but as well as judo. And it's also associated in children with heavy backpacks. You can see the x-ray here. There's some sclerosis seen at the apophysis of the acromion. The literature talks about a bone scan. I really don't think that's necessary. Once again, the x-ray is sufficient in terms of demonstrating the changes, and if it doesn't demonstrate the changes and there's no range of motion loss, it's worthwhile essentially following up, or if you're concerned, you can always arrange for an MRI as opposed to a bone scan period. Treatment is essentially to avoid whatever the aggravating activity, whether it's the heavy bag or the sport, for approximately 5 to 6 weeks. I have this injury in here. This is actually a fasciitis, but it's due to traction. It's kind of a unique physial or growth plate injury. It's also known as little league shoulder. Typically happens in around the age of 12, so anywhere from 9 up to 14 or 15, depending on the child's development. And it's due to repetitive throwing. So that throwing motion is essentially resulting in significant pulling and axial force on the proximal growth plate. Typically they'll have, on examination, limited range of motion as a result, both in abduction, adduction, and internal rotation. And then on x-ray, if you get an x-ray both sides, so they will typically take a look at the growth plate and see if there's widening, as you can see here on the right side. This is a very prolonged period of shutdown, 2 to 3 months. And the goal is to get them back to sport. There's, even after 6 months, 1 in 4 of these will still recur. So the key here is, once you get back, is having that pitch count managed, having them throwing a limited number of pitches, but on a more regular basis, avoiding kind of prolonged periods of rest, followed by ramped up levels of activity is very important in terms of recovery. So spending a lot of time around the education with this injury so that the parents and child understands. We'll talk a little bit more once we get to the medial epicondyle apophysitis around the issues with consulting patients and parents with this. The other complications here are once they start getting the pain in the shoulder, they start the biomechanical change start affecting the elbow, and so they can actually get subsequent medial epicondyle apophysitis as well as UCL injuries. Their ulnar nerve can flare up, and they can get osteochondral defects of the capitellum. The Lessertuberosity, this is essentially a fall on an abducted arm onto the shoulder, and what ends up happening is the tendon of the subscapularis avulsus off at its Lessertuberosity apophysis. Very, very difficult to diagnose. You have to have a very high index of suspicion. It's, I would say, one of the harder things to see on x-ray. So if you had, for example, a wrestler in the ages of about 8 to 12, and they had a fall and they have shoulder pain, and the x-ray is concerning, or they've got pain over the front of their shoulder, this is one where it may be worthwhile to consider a CT scan if you're concerned about specifically lessertuberosity, or if you get the MRI, were to get an MRI based on the injury, and the MRI was inconclusive, but the patient was still in pain, then you might want to consider a CT scan. And once again, the treatment options here this is one of the ones where we're talking about an avulsion injury where surgery may be warranted for improved outcome, but you can also treat these conservatively. Deltoid tuberculosis is essentially typically a chronic avulsion injury. So this is a traction apophysitis where the deltoid attaches onto lateral humerus. You can see classic X-ray findings of the thickening at the end, kind of an irregularity to the cortical surface of the lateral humerus. So case number 1, this is a 13-year-old baseball player. They come in with right medial elbow pain. You have an X-ray, 2 coronal MRIs, and an axial MRI. What they're demonstrating here is widening of the medial apophysis, both on the X-ray as well as the initial coronal MRI. On the second coronal MRI, you can see some edema through the physis, physial plate between the humerus and the medial epicondyle, and then on the axial you can see the bony edema at the site of the medial epicondyle. So this is also known as little leaguer's elbow, repetitive overuse of that flexor pronator group. They can have UCL injuries. They're point tender. They may have some UCL laxity or pain with essentially valgus gapping, and they may actually also have some radiocapitalar tendon because of the valgus force at the medial elbow compresses the radius up against the capitellum. In the early phases, it's slightly widened and then becomes more wide as they continue to play. Once again, the rest is key here, addressing some of the biomechanical issues in terms of rehabilitation. There's very high recurrence rates, and especially in a short season, this is what we're talking about with the fasciitis. This is a very difficult injury for a number of reasons. It typically occurs at the beginning of what is a short baseball season in Canada, and essentially it typically will take them out of the season. So you have a number of things from the competitiveness of the patient to the competitiveness of the parent, as well as the concern for the parent for their child's ability to participate, and as well, obviously, the fact that they've paid and invested in a season and that this injury. So there's a high level of resistance to shutting down, and often this can be done by having essentially quick follow-ups to follow up the conversation, but also to re-examine some of the other joints involved. And the key here, once again, is the rest initially. Typically, I will have these patients shut down for a period of about 6 weeks, followed by a required 4 weeks of being non-tender. Typically, I will palpate the area and watch the patient's face for any kind of grimacing when I'm pressing over the medial epicondyle. Once that's calmed down, once again, a slow, gradual progression with throws and limiting that pitch count is the key, and making sure that we don't have these kind of intermittent periods where we're not doing any throwing followed by ramping up quickly. Case number 2, we got a 14-year-old gymnast, and they come into your office. They're doing about 40 hours of gymnastics training a week, and they have a loss of extension in their elbow. You have 3 sagittal sections of the elbow here, and what you're taking a look at is in the first one, you're seeing essentially the apophysis, and there is a slight area of separation at the end of the olecranon, and you can see this more clearly on the second image with some bony edema on either side, and in the third one you can essentially see some cortical irregularity at the olecranon where the triceps tendon attaches. So these will typically have a dull ache over their olecranon. They'll have a widening of physis on the X-ray. They're typically obviously tender to palpate. Now, the X-ray can sometimes look irregular. This is why the examination is important. So obviously, if they're tender there, this would be in keeping with an abnormal fragmentation. But sometimes the fragmentation can actually be within normal limits. And sometimes it can result in actually a transverse fracture, which can lead to non-union. Gymnastics, once again, baseball pitchers, hockey, and wrestling. Pitfalls here is that, once again, you can have that kind of normal multipartite ossification. So if they're not tender, I wouldn't, on the basis of an abnormal X-ray, necessarily take them out of sport. Now, it's one of the associated injuries we were talking earlier. There's a study out of the States where they took 26 baseball players and did MRIs both their elbows and followed them up to 3 years. And initially 7 out of the 26 had medial epicondyle apophysitis. And by the time they were finished in 3 years' time, either not playing baseball or continue to play baseball, just over half, so the number of patients that had medial epicondyle findings on MRI had doubled, and the number of UCL injury findings had tripled over that period of time. There's also, I think it was about just under a fifth of patients had findings of irritation in their olecranon in that study.